milligram of bupivacaine, that is undiluted 0.2 ml, 0.2 ml with 0.5 ml of fentanyl or 0.4 ml of fentanyl, which gives me about 20 to 25 mics of fentanyl.
Correct.
And in a 1 ml syringe, undiluted, I think it works very well.
So we
don't
got
need to
the point.
also.
Yeah, 1 to 2 milligram of bupivacaine,
Yes.
irrespective of dilution, which we can use with about 20% of motor loss, and that will be acceptable.
Yeah, that's right.
Yeah.
And
So
with just 1 milligram, even that amount of motor block will not be there.
correct.
Other thing which I would like to emphasize here is fixation of epidural catheter is very important, because the epidural which we have given is an ambulatory epidural, and she is being a primary gravida 3 centimeters dilated. She is going to take at least another 8 to 10 hours to progress and deliver. And I want my catheter to be in situ, working well for the entire duration of labor. So generally there are several plasters available, but we are quite comfortable with this, which takes the contour of the back. Many a times what happens is, when the certain obese patients, they have a deep lorotic notch here, and the catheter stands out in between. So you see that you have enough, you occlude this, obliterate this dead space, and keep the plaster properly. Other important thing which you don't see in non-obstetric patient is, this patient will be monitored by cardiotocography on a intermittent basis. Every second hourly is the protocol in my hospital. So when they are introducing the tocography belt underneath the back, this plaster, if it ends here, each time there is a possibility that the plaster gets everted, and after 6 hours the plaster is totally out of the patient and the catheter may fall out. So I fix the catheter from one flank to the opposite flank, so that even if they push their hand for the CTG belt to guide the CTG belt behind the patient's back, it's not a problem.
Yes, yes. We can see that you have used that Mefix probably.
Yeah,
Is
it's
it?
a Surgiplus.
Yeah.
Yes, Mefix.
And
Yes.
what is important, what we have observed is that you have to fix the edges properly. Because
Yeah.
when the patient
Edges.
moves, the edges gets
Yeah.
rolled out, and at the time of
Yeah.
shifting, we often have seen that you come with a catheter outside the body.
थोड़ा cut कर देना.
Satish, I got a question. Satish.
Yeah. Swarup wants to answer
Yeah.
something.
Dr. Sunil Pandya,
Yeah.
this is Swarup. This is the classical situation where we have a catheter in hand and then we
Yeah.
are doing actually epidural.
Yeah.
So my question is, if you get a complication with the dural puncture,
Yeah.
what you do in this
Well,
obstetric patients?
if this happens when I'm doing a patient, first of all, straight away I put the stiletto back into the TUHI needle and I inject fentanyl with bupivacaine. Make her calm, make her comfortable. And once she is comfortable, then I decide, generally the protocol in my hospital is I thread the catheter intrathecally and we manage it as a spinal catheter, because we take care relatively better. The asepsis precautions and other things are little decent. But suppose if you have, if the asepsis condition in your place or in your labor room are not good, then better to give fentanyl, make her comfortable, and then reset the catheter in a space above. Most of the time what happens is, when you end up with a wet tap, suddenly the knee-jerk reaction is remove the TUHI needle. You should not do that, because whatever has happened has happened. At least keep the patient comfortable. The primary objective or goal of giving epidural was to make her, give her pain relief. So establish the pain relief immediately as a first instance. Then you have an option 1 where you put the catheter intrathecally. Option 2, no, I am worried about the aseptic condition in my hospital, remove the catheter, put it in a space above. But both the conditions, all the top-ups to be given by anesthesiologist only. Because with the large dural end of created by 18 gauge TUHI needle, whatever you are going in the epidural space may also go into the subarachnoid space, and you may end up with a multi-compartment block. So you need to be careful.
But the first reaction is most probably due to the significant flow of CSF.
Yeah.
First thing to be done is put the stiletto
Put
back.
the stiletto back.
Then think what dose you are giving.
That's right.
inside and that all other
So that is very important. Other thing is, say that you wrap the filter, either you use the same Portex pouch or the pouch to keep the filter inside, but see that it is wrapped in a sterile this thing. And generally we in our hospital we follow 2 regimes. One is intermittent bolus regime and one is PCA regime. We don't use, in fact we have condemned the usage of continuous epidural infusions in laboring parturients, because after 3 to 4 hours it causes numbness and patients are no longer ambulatory.
Yeah, Sunil, I was going to come to that. Basically, we continuously often
her
use
interview
now
the
these
patient.
infusions, and as you said, you had some problems. So I just wanted to know exactly What dose, what is the rate of infusion and what kind of
Would
solution
you,
use?
you like to interview the patient, ask some questions directly to the patient from the audience?
You can ask
Do
and
we
let
have the
us know.
pain chart?
You
Huh?
ask and let us know what you are going to ask.
Interview the patient in Marathi, no? Just ask the patient.
So in this situation,
The no test dose is a gold standard in any patient, obstetrics or non-obstetric patients.
okay.
What we do is every dose should be incremental dose and every dose should be a test dose. So after 1.5 hours to 2 hours, I activate my epidural catheter and I start off with straight away low dose epidural. If you can see, she is able to flex her legs. Can you ask her to flex the legs? Yeah, she has, as I said, little numbness is there. Yes, that is expected.
Complete pain relief. That's
She has complete pain relief. That's what.
Okay.
The thing, one of the important thing now is the harmony between the anesthesiologist, the patient, and the obstetrician is very important. With intrathecal fentanyl, one thing which you need to remember is there is a transient incidence of intense fetal bradycardia, which is a temporary thing. It is short lasting. But majority of the time, if the obstetrician is a novice, they may push the patient to the theater for an emergency cesarean section. So the reason for transient fetal bradycardia is the intense reduction of catecholamine levels in the patient's plasma
Yeah,
because
that
of
was-
intense pain relief.
That was my next few questions. Quickly,
Yeah.
we want to know
Yeah.
infusion you have stopped. You said what was the reason? What kind of infusion rate and what concentration was on?
Yeah, generally we put this patient either on PCA pump and we don't use the background infusion. As I said, I am against any modality of continuous infusion regimes even with PCA. So we set the PCA on the bolus mode only bolus mode, and the boluses of 6 ml over a period of 4 to 5 minutes given every with a lockout interval of about 15 to 20 minutes. So maximum dosage that is occurring is around 20 ml per hour, and the concentration of the local anesthetic is either if it is ropivacaine 0.1 to 0.125%, if it is bupivacaine 0.625 to 0.1% with 2 mg per cc of fentanyl.
Yeah, a lot of variation because I personally stopped using fentanyl when I was accused that bradycardia was because of fentanyl, and that was my personal response not to use fentanyl anymore. But it is on the house use, I am sure.
Yeah.
The concentration variation obviously very much. As you said,
Yeah.
0.06 to 5%,
Yeah.
to 0.175 to even 0.25% people are using. Now, what is your advice regarding concentration without the use of any narcotic?
See, the thing is, if you are using only local anesthetic,
Yes.
then you can get pain relief, but it is always that the dosage of local anesthetic that is needed is more. Now, virtually with this 2 milligrams of bupivacaine with fentanyl, she will for another 3 hours, at least I expect her not to have any pain, and then we can activate the catheter. We can assess, basically you can assess the pain score every hourly basis, and then you can initiate subsequent activation.
My question is, this is the case where you use combined, but if you
Yeah.
are not using spinal,
Yeah.
then what is the concentration you personally use? And
For a standalone epidural,
epidural, only
yeah,
epidural.
only epidural. In this patient with this pain score, I would have straight away given 20 ml of 0.1% bupivacaine with fentanyl. With fentanyl. If I don't have fentanyl, then probably I may have to use 0.125% bupivacaine, and subsequently as the labor advances, the concentration of local anesthetic may increase. And it may go up to 0.125, 0.15% also.
Regarding PCA, we are not using PCAs, but in syringe pumps which are usually there, we use about 8 ml per hour of concentration might vary.
Yeah,
But
see,
you stopped PCA or you stopped syringe
I
pumps?
stopped syringe pumps. We condemned almost a decade ago, I would say,
Okay.
because we have done at least 3 randomized studies in our own hospitals, and we have found out that the incidence of numbness is almost after 2 hours or 3 hours they become so numb, and the incidence of instrumental delivery rate also is doubled with continuous infusion regimes. I won't say doubled, but increases to almost about 30 to 40%.
What rate of infusion was there? That's what quantity is important.
The rate of infusion is around 8 to 12 ml.
Okay.
8 to 12 ml.
But you did not reduce the quantity and see, or what was the part of trial?
We have used 3 different regimes: 0.065%, 0.1%, and 0.125. When the concentration was low, 0.065, as the labor advanced, this concentration was not enough at that stage, like around 7 centimeters dilatation, and you often ended up giving breakthrough pain top-ups. So at the end of the labor, when you have analyzed the total local anesthetic dose, total narcotic dose, it was much more than what you would have given with intermittent bolus regime or PCA regime.
What I personally do now, when the stretching, perineal stretching starts, that is the time, because upper segments are blocked initially when we give the first dose, so over 1 or 2 or 3 hours depending on the progress. The perineal stretching, at the point of that, you warn the patient and the resident there to give additional dose of equal volume what was given initially. And that
Yeah.
probably has to be sensed earlier, otherwise it is taken as a failure of epidural.
Yeah,
So,
so-
what we do is we give additional dose about say 8 ml of whatever concentration used in the beginning when the perineal stretch starts. And
Yes.
that takes care of it. Do you have any similar experience?
See, perineal stretch also we increase the volume and minimize the concentration, because when you are increasing the concentration at 2 centimeters dilated at the, 10 centimeters dilated, when the perineal stretch is
Okay.
happening, when the descent of the fetal head is happening, you need to maximize comfort, and the
Makes
way
sense, yes.
to maximize comfort is always adjuvant, that is narcotic has to be used. If you are using only local anesthetic, even at this stage, then you end up using a higher concentration. The incidence of second stage
can see
cesarean
that,
section,
yeah? Yeah,
rotation,
yeah.
arrest of rotation,
You can nicely see
mal
the
descent,
demonstrate there.
and these things are quite high.
Thank you, Dr. Pandya.
Yeah,
What
I
is the
think,
other case?
Yeah,
that
yeah,
is
yeah,
going
the
on?
other
Correct.
case has just come, and I'll give the mic to
Yeah, yeah,
Dr.
yeah,
Sandeep
yeah.
Diwan.
Yeah.
Thank you, Sunil, for that excellent demonstration on the epidural and the team also. We are switching on to the next case. It's
Beautiful.
axillary block ultrasound guided.
Yeah, and then